Welcome, everyone. We are delighted to have such a diverse and distinguished group of attendees gathered here. And on behalf of ASPED Education Committee, I would like to welcome you all to our session for today. So this month, ASPED will have two webinars. Our theme for today will be Born, and we'll have another interesting webinar coming on 20th of this month, at which the theme will be Growth. So today's session promises to be an enlightening and engaging experience, filled with insightful discussions and valuable takeaways. So we'll have three unique presentations. The first one will be by Professor Zulf Mughal. So we are so privileged to have Professor Zulf Mughal here today, a well-known figure in the field of pediatric bone disorders, whose contributions have greatly advanced the knowledge of bone disorders in children. So Prof Zulf is consultant in pediatric bone disorders and honorary clinical professor of child health. He graduated from medicine from the University of Liverpool, UK, and received postgraduate training in pediatrics at hospitals in UK and US as well. In 2013, he was appointed honorary clinical professor in child health at the University of Manchester, and in June 2015, he was awarded the Charles Lemenda Award by ICCPH. He is currently employed by Jalila Children's Hospital in UAE, and he has extensive experience in management of childhood bone and mineral disorders, and has published more than 160 reviewed scientific papers, invited reviews, and book chapters. So during the upcoming half an hour, Prof Zulf will talk about the utilization of DEXA scan and their application in diagnosing and monitoring pediatric bone disorders. So we're so delighted to have you here, Prof Zulf, and the mic is yours.
Thank you very much for that introduction, Salva. Good evening, everyone, and salam alaikum. I'd like to thank ASPED for inviting me to contribute to this evening's webinar. So as you've been told that the topic is to discuss the utility of dual energy X-ray absorptiometry or DEXA in children. Why can't I advance my slides? Okay, so these are the learning objectives. So we're basically going to go through the understanding about what DEXA is and the unique challenges of DEXA data interpretation in children, and then sort of touch on the challenges of diagnosing osteoporosis in children, in particular the 2019 International Society of Clinical Densitometry official pediatric position or guidelines, and then discuss a couple of cases. So basically, DEXA is a sort of a special scanner. Here you can see one of my, this is a very old slide, about 20 years old. This is one of our research study patients who is having a lumbar spine DEXA measurements. And the DEXA basically consists of a source of X-rays down here, represented by this diagram here. And it produces two energies of low energy DEXA radiations, and as they traverse through the region of interest, in this case lumbar spine, the attenuation or the absorption of energy of photons as they traverse through the bone, the fat, and the muscle mass, and all the other organs, is then detected by this detector here, and this is shown here. And through this relative attenuation, we can calculate the amount of bone, the amount of fat, and the amount of lean body mass, or surrogate measure for muscle mass in the region of interest, or you can scan the whole of the patient and measure it in the whole body. So that is the general principle of DEXA. The radiation dose is really very small. It's about, for modern scanners, about 7 microsieverts, which is, well, I don't know about where you are, but in Manchester, England, it used to be 1 day of background radiation, so very, very low. The important thing about DEXA is that it was really developed for adults, and children are not small adults. If you're going to use a DEXA, then you need to have good normative data, which is important, just as if you're going to measure a child's growth, you need to have growth charts which are appropriate for your population. The DEXA data interpretation in children is different from that in adults. So what can we measure with DEXA? So the first thing is the bone mass in grams. So that's the total amount of bone within the area that is being scanned. The next one is the area, which is combined aerial bone density, which is, note here, it's in grams per centimeter square, not in grams per centimeter cubed. And the other thing is that it looks at both cortical and trabecular. Cortex is the outer shell of the bone, trabeculae in areas like the spine, and the distal ends of long bones is the honeycomb bit or the trabecular bone. The DEXA is not able to differentiate between cortical or trabecular bone. The other point is that it will give you some idea of bone geometry. In other words, how wide the bones are and how tall they are, because the strength of a bone not only depends on the amount of bone contained within its periosteum, but also in size. So narrow or slender bones, even if they're adequately mineralized, will have significantly reduced bone strength, particularly when it comes to bending or torsional strength. It also looks at lean body mass, which is a surrogate measure of muscle mass. And muscle is very important because the largest load on the skeleton comes from muscle. And then, of course, it gives you fat mass. And fat is important in many ways because fat and bone is now becoming a very interesting area of research. But also it will give you, if you're interested in, for example, doing body composition studies, then it will give you fat mass in your patients with metabolic syndrome, for example. What DEXA is not able to measure is the volumetric density, which is the true bone mineral density, which is expressed in grams per centimeter cubed. It will not give you the separate cortical or trabecular bone densities. So here you have cross-section through one of the lumbar spine bodies, and you have got the outer cortex and the central cancellous or the trabecular bone. And it is very important to actually ideally measure this selectively, because if you have a high turnover bone condition, then trabeculae are going to be affected first. For example, treatment with glucocorticoids, anorexia nervosa will selectively pick out the trabeculae, whereas you cannot actually measure that separately by DEXA. The other thing which you don't get is cortical thickness. So this is a scanner using a PQCT, peripheral quantitative computer tomography of the distal radius. And you can see at the proximal radius, you can see the outer shell, the cortex plus trabeculae, but in the around about sort of 33% side, you can actually look at the cortex and measure the cortical thickness. So in conditions such as hyperparathyroidism, the cortices will become very thin. So it's important to recognize the limitations of DEXA. So the commonly measured sites are the lumbar spine, L1 to L4, the proximal femur, and usually the femoral neck, which in pediatrics poses many challenges because the morphology of the femoral neck changes so much during development that in Manchester, when we did a lot of normative studies and a lot of sort of evaluation of this, we decided that we would not even look at that until the age of 10 or 11. And then you can do the whole body. So here you can see not only the whole body bone, but you can see red the lean body mass or the fat mass, and also the fat mass as well. Because in children the head is relatively large, by convention we tend to sort of remove the head from analysis because the head being large can mask a small change in rest of the skeleton. So it's known as whole body less head bone mineral density. Okay, now this is perhaps one of the most important slides. And here you can see two cubes of made from the same material. So they should have the same density. And indeed, if you look at the volumetric density, it's the same, 2 grams per centimeter square. But this is a smaller one, and this is a larger one. Now in DEXA, what you're doing is you're looking at the mass of this cube or this cube divided not by the volume, but by the projected area shown here. And this is very different. So for the smaller cube, the aerial bone density is 4 grams per centimeter square, whereas for the larger one, it is 6 grams per centimeter square. Now, the smaller cube could be a healthy 9-year-old child whose height is on the 10th centile, and the bigger cube could be a healthy 9-year-old boy whose height is on the 90th centile. So they're both healthy. They should both have roughly the same volumetric bone density, but they have totally different areal bone density. Now, herein lies the problem. So the size actually really matters in DEXA. So unless you account for size, unless you look at the sort of delayed maturation of the skeleton, you will make erroneous interpretations of areal bone density. The other thing you want to know is the effect of any disease on bone size. So you can ask using the Molgards, this is based on the paper in Archives of Disease Childhood, does the patient have short bones? Does the patient have slender or thin bones? Or does the patient have light bones? And we'll go through these stages because these are quite important. This is allometric sort of assessment of bone mass. So the first step is really looking at height or bone mineral content for height. So if you have a short person, he's going to have short bones. If you got a tall person, you're going to have tall bones. So it's just simply looking at the height, which really means that the first step in interpretation of DEXA data starts by looking at height. The second one is to look at the bone mineral content against bone area, which you can get from the DEXA. So this will tell you whether the bones are heavy. So if you have more bone for your bone area, or the bones are light if you have less bone for your bone area. And the third step is bone area for height. So this is really looks at wide bones or narrow bones, because as I mentioned previously, you can have adequately mineralized bones, but if they happen to be slender, the force which is going to be required to sort of break them is much less. So you should look at size, and this is the way you can use DEXA to get an insight into the contribution of bone size to possible skeletal fragility. So I spent several years in this special research van that we had in Manchester, and we went to schools and generated normative data, which we published in Archives of Disease in Childhood. For the hologic scanner, there are two main scanners, the hologic and the GE Lunar. They're both different scanners. They have different softwares. They have different data acquisition, and you can't if you're doing serial assessments, scan the child on one scanner and then switch them to another scanner. And this means that if you're seeing patients from different hospitals, then you need to be cognizant of that fact. And then also in England and Scotland, Wales, in the UK, we pooled together all the robust databases from all our major bone centers and published reference database for over 3,000 patients. And this is the largest pediatric database in the world. And I hope that one day, the centers within the ASPED community will get together and produce the local reference ranges. Now, I mentioned that the size is important. So how do we overcome size? Ideally, we want to look at the volumetric bone density, which DEXA does not provide. But you can actually measure what's known as bone mineral apparent density, which is an estimated volumetric bone density. For example, at lumbar spine, where you have L1 to L4 vertebral bodies, which are scanned, so you have bone mineral content and bone area. Instead of dividing bone mineral content by bone area, you can, if you divide bone mineral content divided by bone area to the power of 1.5, you can get what's known as BMAD, which is approximately modeling the vertebral body as a cube, and therefore it's a derived volumetric bone density. And what we found was that it actually helps to smooth out the variation that you get by size. So, and Nick Crabtree from Birmingham, that BMAD is in fact one of the stronger prediction of fracture risk in children. So BMAD calculation is important. And as I mentioned that the DEXA does not give you the separate bone density of the cortical and trabecular bone. If you really want that, then you need to use a CT scanner, which will actually give you selectively volumetric bone density. And in my last hospital in Manchester, we routinely used to do this. But the radiation dose is much higher. You can actually use any CT scanner to do this, provided you have appropriate software. Now, the largest load on the bone comes from muscle. So when the muscles contract, they deform the bone, and that deformation then stimulates the bone to make the osteoclast to actually put more bone on the outside to stop it from fracturing. At the same time, if you go into the state of disuse, then there's less loading and you start getting bone resorption. And this is the slide which was produced by my late friend Hans Sichel, who is an inventor of PQCT scanner, which illustrates this process that the muscle contraction is deforming the bone. And if you, this is the happy zone which we are in, this is the immobilization dose. But if you start suddenly going to the gym and starting doing lots and lots of exercise, then the bone is loaded more. You need to make it stronger. And so, you know, this is then you'll get build bone on the outside. So the importance of this is that you should ideally look at the functional relationship between muscle and bone. And the way we do that is ask the question, is the muscle mass or lean body mass, which you can get from the whole body less head scan, adequate for height? If the answer is yes, then the next question is the amount of bone mass or bone mineral content appropriate for the muscle mass? If the answer is yes, then you're perfectly healthy and you can do headstand and you'll be fine. But if your amount of muscle mass or lean body mass for height is fine, but the amount of muscle mass is not adequate, so the amount of bone mass is not adequate for muscle mass, then you got a primary bone defect like osteogenesis imperfecta. If, on the other hand, you have inadequate amount of muscle mass for your height, but the amount of bone for your muscle mass, small amount of muscle mass is adequate, then you're looking at secondary bone defects. But in practice, you actually often have combined mixed bone defects, both both the reduced muscle and reduced action of muscle on the bone due to the disease process, due to the inflammation. So this is the Crabtree model, and it allows you to interrogate the role of muscle. So these are the sort of measurements ideally you should be making. Size-corrected bone density is look at the size of the bones and look at the adaptation of the bone for the lean body mass, ideally in a DEXA measurement. The other thing which is very, very important is assessment for compression fractures of vertebral bodies, which can occur insidiously in children who have markedly reduced skeletal bone strength. And traditionally, of course, we would use a radiograph here. For example, this is a lumbar spine radiograph, and this is a thoracic radiograph. And here you can see that there are some fractures, but in the thoracic area, which is where most of the fractures tend to be, there is often overlying ribs, and there are overlying lung shadows, the pulmonary and arterial vessels, which can mask any these fractures. And because DEXA is a tomographic effect, as I mentioned, there are two energies which are going through the area of interest. It can actually give you much nicer images as shown here. So this is the same VFA image on the same patient who had these two radiographs. And you can see that the morphology of the vertebrae, particularly in the thoracic area, is much, much superior to that of a plain radiograph. And also, this is available at the point of care when you do the DEXA care. Furthermore, the radiation dose of vertebral assessment by DEXA is minuscule, 12 microsieverts, compared with 200 microsieverts for a standard pediatric chest radiograph. Information effect, and as I mentioned, it gives you much better visualization of the thoracic vertebrae. So assessment of vertebral fracture assessment has now become an integral part of DEXA measurements, and the two DEXA scanners, the Hologic and the GE Luna, both have this facility. The GE Luna is superior, but the newer versions of Hologic are also give you very nice images of the spine. Okay, so now let's come on to the guideline for diagnosis of osteoporosis in children. Now, if you happen to be an adult and you have a DEXA scan, and if your T-score, which is an interesting concept, this is not Z-score or Z-score, but this is T-score. This is looking at an individual's adult's bone mass compared with his or her peak bone mass that is the maximum amount of bone that was accrued at the end of skeletal growth and maturation. So roughly about 21 years in ladies and about 25 to 26 years in boys. So if your T-score is minus 2.5 or less, you can actually stamp the osteoporosis on the forehead, and that adult subjects is then can be given bone protection in form of bisphosphonates or hormonal replacement, whatever is appropriate. This cannot be applied to children. The main thing is that you cannot make the diagnosis of osteoporosis using DEXA. Okay, this is important. And this is happening all the time. And since in the last 9 months, I've seen several patients inappropriately treated because the diagnosis of osteoporosis is made on DEXA alone, and I'll come on to the one example. So the International Society for Clinical Densitometry, after reviewing all the available literature available and expert groups, and I was involved in not the 2019, but the 2013 and the previous guideline development, came up with this, that the diagnosis of osteoporosis in children and adolescents should not be made on the basis of densitometric criteria alone, in other words, on the basis of DEXA. The second, and this is why assessment of vertebral fracture assessment is very important, one or more vertebral compression fracture, in other words, the loss of height at any point in the posterior, middle, on the anterior part of the vertebral body, greater than 20% is indication of osteoporosis, regardless of your bone mineral density value. The third point is that the diagnosis of osteoporosis requires presence of both a clinically significant fracture history, and I'll come on to that, and low bone mineral content or density, which is adjusted for size and gender. And the significant fracture history is really 2 or more long bone fractures, ideally fragility fractures by the age of 10 years, or 3 or more long bone fractures by the age of 19 years. So this is really should be the basis for diagnosis of osteoporosis in children. And this statement is very important. You cannot make the diagnosis of osteoporosis based on the DEXA scan in children. Let's finish off by looking at a couple of cases. So George is a 9-year-old boy with Crohn's disease, which was diagnosed when he was 6 years old. Control of his disease was very poor, and he had received elemental diets. He had had methylprednisolone pulses as well as oral steroids during his exacerbation of his Crohn's disease. He had also had the bowel resection where there was a really bad segment of Crohn's, and he had been tried on at least 1 or 2 biologic agents to try and get on top of his control of his disease. He had not suffered any fractures or complained of back pain. If you looked at his growth, then his height was towards the lower end of, on the lower side with a Z-score of minus 1.3. The weight was actually not too bad in spite of his nutritional challenges. His ESR, in spite of all these measures, and CRP remained high. His bone profile were all completely normal. So he was referred by his gastroenterologist for assessment of his bone health. And assessment really starts with taking a detailed history, asking about fractures, how did they occur, what was the force required. So detail is very important. Backache should never be ignored. And then, of course, you need to do a quick musculoskeletal examination, PGALs, which is something that fellows are drilled into and are constantly asked about when we have our teaching. Pubertal assessment is very important. You should estimate dietary calcium intake, and this can be done very quickly in clinic. You don't need to refer them to the dietitians. Of course, check the labs, the vitamin D status, PTH, bone biochemistry, and then the DEXA, spinal radiograph or a VFA, bone mineral density, and in a few cases we do bone biopsy and histomorphometry of these things. So that is the sort of clinical menu. This is what I do in clinic all the time when I'm assessing a child with thing. So DEXA should be in the context of all this sort of clinical evaluation and appropriate investigations. So let's come back to George. His whole body less head aerial bone density was low, but then we know that he's short, and being short will reduce it, but his height is not as his height standard deviation score is not as low as this, so he genuinely may have low bone mineral density. His spinal bone mineral apparent density, this is size corrected, was almost -2. Plus minus -2 is sort of -2 or +2 is regarded as our sort of cutoffs, arbitrary cutoffs. Then if you do the Molgard, his height for age standard deviation was okay. His whole body less bone area for height was also fine, but the whole body less head BMC for bone area was low, which is the same sort of magnitude as aerial bone density, which is effectively what it is. So this really tells you that for the whole skeleton, the amount of bone contained in his skeleton is likely to be reduced, even when you take into account his height. And then what about the Crabtree model? So his whole body less had lean body mass. So the amount of muscle mass that he had for his height was significantly reduced. So the nutrition, the disease, the inflammation has reduced his muscle mass. But the amount of bone mineral content for his lean body mass, so the small amount of muscle mass that he had, was actually okay. So the main problem here is reduced muscle mass, reduced loading of his skeleton due to his disease, but the amount of bone for his muscle is fine. So it's already giving you a lot of useful information as to the causation of his low bone mass. And so the interpretation of George's DEXA results are that he has undermineralized bones, he has reduced amount of muscle mass for height, normal amount of bone mass for his low muscle mass, so he's got secondary bone problem. Further investigations that need to be done, of course, VFA is very important, and when VFA was done, then he was found to have asymptomatic compression fracture of T2 vertebral body, as shown here. And the management of this, of course, optimizes nutrition. Even though his weight is roughly on the 50th centile, it's probably all fat. You need to get him to acquire muscle, build muscle, control his inflammation better, possibly with better biologics. And of course, because he's got a compression fracture, and we know that once you get one fracture, the adjoining the vertebrae are soon start going to go. So start him on bisphosphonates. So this is logical, appropriate management after full clinical evaluation and logical interpretation of DEXA in somebody with chronic illness and inflammation, which is inadequately controlled. Let's go to a recent case. And Ahmed is a 15-year-old boy with sickle cell thalassemia disease and G6PD deficiency. He's suffered many painful crises, and the treatments have included blood transfusions for low hemoglobins, and during severe painful crisis, he's of course on folic acid. Because of hypersplenism, he's on penicillin, vitamin D, and paracetamol for pain. No history of fractures. He's never had back pain. Ahmed is short, weight is actually fine, and his bone age, as in many patients, is reduced in comparison with his chronological age. So this shows his sort of height, and this shows his bone age here. For what it's worth, and Hussain is going to talk about bone health index, which is using an AI tool to look at the metacarpal thickness and deriving a bone health index from it. It was reduced. But remember, he's never suffered fractures, and he's never had pain. So and his lumbar spine, aerial, not BMAD, is markedly reduced, and you can see the dot here. And these are the US enhanced normative database. He did not have a VFA, though that machine that was used is perfectly capable of doing a very nice VFA. This is a GE Luna machine, but because of his back pain, intermittent back pain, radiograph of his spine was done, which actually did not show vertebral fractures, but there was a defect in pars intercalaris of L5 here, and he had grade 1 spondylolisthesis with L5 slippage or S1. Whether that was contributing to his back pain is a moot point, but basically he did not have compression fractures of vertebral bodies. He had low bone mineral density, even possibly allowing for his height, but he was actually given bisphosphonates, not by us, but by another physician, in fact, an adult doctor. And he presented 48 hours to the emergency department with fever and pain. And being a sickle cell patient, fever, was taken very seriously, and he was hospitalized and given antibiotics. But when he had the bloods done, he was also found to have low ionized calcium and low total calcium, because he was not given adequate amount of calcium, which should be done before you give zoledronic acid, and optimize vitamin D. His serum 25 hydroxy vitamin D was a little bit on the low side. The reference range is 30 to 100. In fact, in the UK, this would probably be okay. But his parathyroid hormone was very high, suggesting that he probably had chronic dietary calcium deficiency. So this is really uncritical use of bisphosphonates based on DEXA interpretation. Having said all that, I don't think any harm came from his treatment with bisphosphonates, because there is now a drive to sort of perhaps try and control the pain, chronic pain that you get in sickle cell patients, and the deformation of the vertebral bodies through infarctions of the end plates that you get, possibly by bisphosphonates. And there are a number of papers appearing in that. But it's not this is not a logical way of treatment. And this is unfortunately quite common, which I've seen since coming here. So in summary, DEXA alone cannot be used to diagnose osteoporosis in children. DEXA was designed for adults. When you're using it in children, you need to be cognizant, you need to be aware of its limitations and be able to adjust. So children are not small adults, and aerial bone density, that's grams per centimeter squared, is affected by bone size independently of its volumetric or true bone density. And interpretation of DEXA in children really should require size corrections, such as estimation of BMAD to reduce the effect of bone size. And you should have separate assessment of bone size and mineralization by, for example, looking at the Molgard approach, and assessment of the muscle-bone relationship, how the lean body mass or muscle mass may be affected by disease, and its impact on bone mineralization is very important. So with that, I'd like to thank you for listening to me, and I'll be happy to answer questions at the end whenever our chair decides. So thank you very much.
Okay, thank you. Thank you very much, Prof Zulf, for this marvelous presentation as usual. And it's very interesting that how this new modality, the DEXA scan, have emerged in the last 30 years, probably last 15 years for children, and how it helped in diagnosis and monitoring bone disorders in children. But what I like more in the presentation, that you're emphasizing the point that DEXA scan cannot be utilized and used for diagnosis the osteoporosis in children, and we have to incorporate all the clinical criteria and the number of fracture, Bigal examination, and also as to diagnose osteoporosis in children. Thank you very much for your presentation. So our next speaker is Dr. Hanan Al-Thiabat. Dr. Hanan is pediatric endocrinologist and assistant professor at Jordan University of Science and Technology, and also at King Abdullah University Hospital. And she has been selected recently to join our ASPED Education Committee Task Force Group to help in many educational activities. So she will be presenting in the upcoming 10 minutes a case presentation related to our theme for today. So Dr. Hanan, welcome to ASPED webinar.
Good evening.
Okay, good evening, Hanan.
Thank you, Dr. Salwa, for this presentation. Thank you, all ASPED's Educational Committee, for providing me this opportunity to present my case. My case title was Vertebral Compression Fracture as the Only Presentation Signs of Acute Lymphoblastic Leukemia. The history: she was a 7-year-old girl who was previously healthy. She presented with severe back pain of 1 month duration and history healthy, presented with severe back pain of 1 month duration and history of falling down 6 weeks prior to her presentation. The pain has been intermittent and getting worse over time. She needs help with ambulation. It does not radiate to other sites or joints. It's exacerbated by activity and wakes her up from sleep. Conservative treatment with analgesia did not improve the pain. The patient also experienced night sweats and weight loss. Her physical exam was totally normal. She has a normal growth parameter for her age, sex, and target genetic. She was prepubertal. There is no any focal neurological deficits. Her muscle power and reflexes were normal as well. And there is no any signs of ecchymosis, pallor lymphadenopathy, or organomegaly. Her investigation, her CBC was completely normal, normal hemoglobin, white PC, and platelet. Her bone profile also normal. Her liver function, kidney function test, thyroid function test, blood film, Celix screen were also normal. We did for her as primary investigation for her back pain, MRI spine. The MRI spine, as you can see here, it showed multiple compression in the thoracic and lumbar area. There was no spinal compression. However, in T2 section, as you can see, there was increased bone marrow signal intensity, and this homogeneous enhancement on both contrast image is matter of concern. So at this point, we diagnosed her, the working diagnosis was vertebral fracture after falling down. But there is many questions was not answered by the history. This does not explain her general symptoms, fatigue and weight loss. There was an increased bone marrow signal intensity in T2 MRI spine. There was this discrepancy between mechanism of trauma and severity of vertebral fracture, and also timing of the symptoms and her trauma history. This is her scan, which obviously show low bone mineral density. Her Z score for her age and sex was -6.3. Now, she has osteopenia in addition to vertebral fracture, so we diagnose her with osteoporosis. But again, this does not explain the previous questions about her MRI finding, which mostly represent bone marrow infiltration, for which we decide to do bone marrow biopsy. And for bone marrow biopsy, revealed hypercellular marrow with more than 90% of the cells being L1 blast cells. So in conclusion, she has vertebral compression, fracture, osteoporosis, infiltration of bone marrow with blast cells. So we want to ask Prof Zulf about many debates question. In her case, is the DEXA scan was enough? What is the role of MRI spine? And if we decide to treat her with bisphosphonate, what is the duration of bisphosphonate treatment? Thank you all for your listening.
Thank you, Hanan, for this case, which is I think Prof Zulf's presentation also will help to answer many questions, but we'll leave the discussion to the end. So because of the time, we'll move to our next speaker. So our next speaker is Dr. Hussain, and it's my great pleasure to introduce my colleague, Dr. Hussain. So Dr. Hussain is pediatric endocrinology consultant at Sultan Qaboos University Hospital, Oman, and he was trained in the UK and achieved his CCT in 2017, then became a fellow of the Royal College of Pediatric and Child Health UK, and recently a first distinction awarded by AACE. He has completed a master's degree in global management from University of Salford in 2024, and he's very interested in collaborative work in the field of pediatric endocrinology and diabetes. Dr. Hussain, of course, all know him. He's our dynamo in ASPED, mashallah, and we are so keen to listen to his presentation. So Dr. Hussain, the mic is yours.
Thank you very much, Dr. Salwa, for your kind introduction. So I'm going to talk about bone health index in children and adolescents with congenital adrenal hyperplasia. So as an introduction, that with patients with CAH, they do require treatment with steroids. And we know that the negative steroid effect on the bones. But interestingly, we think that the counteract mechanism of androgens on the bone might counteract the negative effect or the adverse effect of glucocorticoid on the bone. So we wanted to use the bone health index, which is a tool to measure bone health in a way different from the DEXA scan that was explained earlier to us. So a bone health index is typically used in pediatric population to monitor bone development and health. And it is basically done by a software to measure the cortical thickness of the 3 metacarpal bones here. And it performs 100 independent measurements of the thickness of the bone, thereby could obtain much better precision than the old manual method in assessing the bone health in here. It can be used as a useful tool for initial screening, especially in cases where full body DEXA scan might not be practical. So advantages of bone health index and using a software to measure that, such as Bone Expert, it's a relatively quick and simple procedure. There's less radiation exposure compared to DEXA scan. It's useful for monitoring the bone health in children where other methods might be less suitable. Limitations of using the bone health index, basically, it is limited to assessing bone health in the hand and may not provide a comprehensive overview of the overall bone density, and is less commonly used and recognized compared to DEXA scan. So aim of our study that was carried out at Alderhay Children's Hospital in Liverpool was to examine the relationship between bone health index and standard deviation scores calculated by the software Bone Expert. And we looked at the number of variables such as bone age, the hydrocortisone dose in milligram per meter square per day, and the mean 17-hydroxyprogesterone concentration on 24-hour blood spot profile. It was a retrospective study of data collection, and we classify the age of children less than 10 years and 10 years or more, taking into consideration the puberty into this classification. Bone age was reported according to Tana White House 2 reference data. So our results, as you can see here, so we had 27 patients included in this study. 15 of them were male. Their age was between 10.7 plus minus 3.4 years. And as you can see here, less than 10 years, we had 12 patients, more than 10 years, 15 patients. The bone age for the younger children was a little bit advanced to 11.1. That's the range between 6.39 to 14.3. But this is that's the median. For those who are more than 10 years, it is more advanced, reaching 14.9 years. This is the chronological, the bone age minus chronological age. How much is the bone advanced here as a median? And the bone health index standard deviation score was lower in the younger age group as a median. It was minus 0.65, whereas it was minus 0.3 for the older group. The mean 17-hydroxyprogesterone was 30.2, slightly higher compared to the older group. And the hydrocortisone doses median was within the normal recommendation of about 10 milligram per square meter per day. So what we found here, like I just said, that bone age was advanced in both age groups, and bone health standard deviation score was less than minus 1.5 actually in 4 subjects, and that making like about 18% of the whole studied patients. The bone health index standard deviation score was not related to either the hydrocortisone dose or 17-hydroxyprogesterone concentrations. We could not find that kind of link between them. However, bone health index standard deviation score correlated positively with chronological age and bone age advance. And what we mean by bone age advance is the difference between the bone age and the chronological age. So it was positive correlation with R of 0.48 for people less than 10 years, slightly less for the older age group. And that's our finding. So conclusion from that, as anticipated, we observed modest bone age advance, consistent with modestly elevated 17-hydroxyprogesterone concentrations in this cohort of patients. The bone health index standard deviation score was less than 1.5 in 18% of our patients, suggesting a negative effect of hydrocortisone persists despite the protective effect of elevated androgens. And these relationships might be more evident in large cohort of patients. The clinical significance of this observation, if any, is unknown. However, osteoporosis in adult patients with CAH is reported, and this observation deserves further evaluation in large cohort of studied patients prospectively. And I would like to thank the people that I worked with at the time who we carried on this study. Thank you.
Thank you very much, Hussein. Very interesting findings. And just to ask, what is the dose of the average dose of hydrocortisone that we're giving to these children? Is it like 10? 10 milligrams.
As a median, yes, as it's shown.
So thank you, Hussein, for your presentation. And now we'll go to we have a lot of questions. So the first question is for Prof Zulf. It's from Monjunath. And she asked or he's asking about how to know if muscle mass is adequate for bone. Prof Zulf, the mic is...
Yes, I'm sorry, I was muted. So basically, as I showed that you look at the first stage is to look at if the muscle mass is adequate for height, which is, you can measure your height, you measure the total amount of lean body mass. And the next stage is then, of course, you look at the bone mineral content for muscle mass, which, of course, you've got your lean body mass, you've got your total bone mineral content. And, if you have good reference data, then, you can sort of do this very quickly. And in fact, the modern scanners try and give you an estimate of this. So if you get into the details of looking at the DEXA output, you should be able to derive this information. But in fact, you only get about sort of 2 or 5% of the data which is collected by the DEXA scanner from what I've found since I moved into this area. So this is why, if you're really going to use DEXA, you need to understand it. You need to get into the nitty-gritty and being able to use the appropriate data and use it appropriately. So it can be done very, very easily. And if you look at the right bits of the DEXA output.
Okay, thank you, Prof Zulf. So the other question is from Saria. The question is, when you will recommend intervention with zoledronic acid in children with cerebral palsy with impaired DEXA scan -4 score, but no fracture undergoing active physiotherapy?
Yeah, so the whole area of cerebral palsy, and we've written a number of papers on this, is a very difficult area. If you measure bone density in anybody who's immobile, you will find actually the bone density will be low. But in fact, there's a very nice study done by Bonnie Specker and colleagues. They actually found that if you look at the long bones, and in fact, majority of the fractures occur at the ends of long bones. 60% of fractures in cerebral palsy will occur around the knee, which is where the large metaphysis meets the very slender diaphysis, because that diaphysis or the shaft of the bone has not been loaded by the muscle. And the bone density will be low because the area is very low, the child is very small. But in fact, if you look at the actual bone density using peripheral quantitative computer tomography, that is normal. So the problem is not the density, it's the size. So I mentioned that if you want to look at the bone strength, you need to look at the size. We had a very pragmatic approach that if the child with cerebral palsy has had 2 or more fragility fractures, then we gave bisphosphonates on empirical grounds. Remember, bisphosphonates are not licensed for children, even though they've become de facto the treatment for osteoporosis. They've never undergone clinical trial and approved by FDA or EMA or other bodies. So we are actually using them off license. And the evidence in cerebral palsy of benefit of bisphosphonates is limited, but we use them and it helps to reduce the pain. There is some observational data to suggest that it may reduce the risk of fractures. So our pragmatic rule was 2 fractures, give 1 year of treatment and then see what happens. But we actually found that there were some more fractures which occurred in cerebral palsy between the treated and untreated bone, the interface fractures which occur in any child, but more commonly in cerebral palsy. So not an easy area, I'm afraid.
Okay. Thank you, Prof Zulf. So today is lots of questions to Prof Zulf. I encourage all to ask questions to other 2 speakers. So the other question is from Bian. Will oral calcium carbonate or cholecalciferol intake on the day of the DEXA scan affect the result? Radiologists in my center requested above supplements to be withheld, otherwise in scan or the scan will be postponed.
No. No, I mean, what you're measuring in the skeleton is what has accumulated over years. And giving one dose of calcium or one dose of vitamin D will not make any meaningful change which can be measurable by DEXA. So I disagree with that premise.
So thank you, Ghada, for your comment. And Anita, yes, the presentation will be available on the ASPED websites. And other question is from, again, another question is, T-score minus 2.5 in children means can be given bisphosphonate. Can you please explain?
Yeah, T-score should not be used in children. So it's like a T-score is comparing the peak bone mass with the bone mass of the child. It's like looking at an adult skeleton. So a fully grown 18-year-old lady's height and comparing that with 5-year-old's thing. So T-score should be eliminated. You should use Z-scores or standard deviation scores. So in fact, the modern scanners actually automatically stop giving you T-scores. So that should not be done. So you will actually diagnose lots of, in fact, every child will have low T-score. I mean, if you compare a height of a 5-year-old with a height of an adult, they will be low. And this is what T-score is equivalently.
Thank you, Prof Zulf. And the other question is from Adil. Adil is from Cameroon, and welcome, Adil. She is the General Secretary of ASPE, which is African Society for Pediatric Endocrinology and Diabetes. And thank you for you to be here in this webinar. So she's asking regarding giving vitamin D alone to patients with CH. The question is for you, Hussain. Giving vitamin D alone to patients with CH or hydrocortisone, can it prevent osteoporosis? If no, is there any other medication to add on it?
So I don't use this as a prophylactic treatment for patients with CAH, but what we do is basically we need to make sure that the child is taking adequate amount of calcium as well as getting exposed to sun rays and eating food that is rich with vitamin D. But I do not recommend that to my patients, that to take vitamin D as a usual kind of supplementation, unless the patient is at risk of vitamin D deficiency. For example, if the child is not getting exposed to sun rays or not getting the opportunity to play around in sunny weather. At that time, then yes, perhaps we just say that need to take multivitamins, just the normal daily requirement. But I'm not personally aware of giving vitamin D as a prophylactic treatment patients with CAH. Prof Zulf, I don't know if you want to add on this.
No, I totally agree with you. I think we should just optimize the vitamin D and calcium intake, but the evidence of that this will mitigate against the future risk of osteoporosis in CAH. I don't think we have any data, but of course we should optimize vitamin D in everyone. Salwa, if I may be allowed to comment on
Yes.
Dr. Hanan's excellent presentation. I thought that was a brilliant presentation. Well done on diagnosing and persisting with your investigations and diagnosing leukemia. That's an amazing story. It's not the first time I've come across this, and so I think your patient actually had edema in one of the vertebral bodies after a fall.
Yes,
and in
T2
fact,
signal, yeah.
Absolutely, yeah. So when you get acute trauma on T2, you will actually see edema. And so you could have easily put it down to that's the recent fall, which has led to this compression fracture. But the important thing was that if it was a minor fall and it led to a compression fracture, then that tells you volumes that the bone strength is impaired. So I think your decision to actually proceed with Trafine to actually diagnose leukemia was absolutely brilliant. And I think that's a very, very important lesson. And this is the sort of story I've seen many, many times, and leukemia has often been forgotten. Patients have been put in braces by spinal surgeons because they think it is acute trauma to the spine which has done it. and the patient then deteriorates and advanced leukemia or advanced sort of cancer is diagnosed. So very, very, very important learning point there. Well done, well done. Very, very, very important.
Thank you.
Thank you,
you
Prof.
for your
Do you have any comment, Hanan? Do you want to highlight anything?
No, yeah, my 3 questions. First of all, if we do just DEXA scan, we will miss the finding in MRI spine, which
Very
is
possibly. Very possibly, because I think it was a very low fracture affecting particularly one body. And the other thing is that you can get exaggerated sort of response. So because you got compressed bone mass, you're now then dividing by a smaller area, which will spuriously give you higher areal bone density. So it could actually mask it, which again illustrates the weakness of DEXA. And so in a way, DEXA might have taken you to maybe reassuringly normal, and you said, okay, DEXA is normal and I don't need to do anything. So
Yeah.
in fact, DEXA could have been detrimental, I think, in this patient.
Okay. The second question, what about the bisphosphonate therapy? Since she will start on chemotherapy, steroids.
Yeah, very good. So I think I mean, if you look at leukemia at presentations, many leukemic patients, such as even some Crohn's patients, will actually have some a degree of compression fractures of vertebral bodies. But as you treat them, they reshape. But if they got symptomatic fractures, then you can accelerate their healing by giving them bisphosphonates. They're very good for the pain. They will help reshaping of the vertebral bodies. So I would sort of treat your patient possibly for 1 or 2 years. But if the patient is pre-pubertal and there's a growth left, growth is a very good friend for us, because that helps to reshape vertebral bodies. But it's in a growing child, in that context, would actually have helped.
Okay. Thank you.
Thank you, Hanan. Thank you for this nice case presentation. So 2 questions for you, Hussain, from Ghada and Amani, and about how you assessed the PHI in your study.
So bone health index is measured using a software called Bone Expert. And Bone Expert, you could buy it from the company. I think they charge, last time I checked with them, like I think $8 per X-ray. And the software can be linked with the PACS system. So once you got the electronic, the digital X-rays, that software will be able to analyze the bone thickness of the cortical thickness of the metacarpal bones. Yeah.
Okay, thank you, Hussain. So another question from Amani to Prof Zulf is, shall we continue the hyaluronic acid to OI cases after normalization of bone mineral density as osteogenesis imperfecta?
Yes, so that actually is a very important question. It raises another sort of utility of DEXA. DEXA is very useful in looking at the response to treatment. And if you have a patient with osteogenesis imperfecta, they will have low bone density. When you treat them, the bone density starts to improve and normalize. What you don't want to do is to overtreat them, because you can actually, if you know from the adult studies, after 5 years of giving oral bisphosphonates, the number of fractures starting actually increasing. So this is why in adults, they actually have what's known as bisphosphonate holidays. We don't have bisphosphonate holidays in children, because if you stop treatment in a growing child, you'll have treated bone and untreated bone, and that interface between treated and untreated bone acts as a stressorizer, and this is where you get interface fractures. So once your bone density starts becoming normal, then you start reducing the dose of zoledronic acid. So if you're using 0.05 milligrams per kilogram every 6 monthly, maximum dose 4 milligram, then you can start going down to 0.025 milligrams, so that you're not over mineralizing the skeleton. And you carry on until the growth has more or less finished, as judged by the usual criteria that you use in endocrinology, by looking at the significant decline in growth velocity or closure of epiphysis around the knee.
Okay, thank you, Professor. And there is another question from Dr. Samia. Do you recommend calcium supplements before and after bisphosphonate infusion in the presence of normal calcium level?
Yes, I think that's a very important point. So one of the effect of zoledronic acid, as you know, is that it completely shuts down the osteoclast. So any calcium that is coming from the skeletal pool just stops. And so if you have suboptimal dietary calcium intake, but more importantly, if you're vitamin D deficient, there's a real risk of hypocalcemia occurring, like in the second case I mentioned. That child actually had woefully low intake of calcium, and the high PTH was a marker of that, and he had also suboptimal vitamin D. So always three things that you must do is to make sure that the dentition is normal. Even though the avascular necrosis of the jaw is rare in children, but dental health must be immaculate before you start bisphosphonates. Secondly, optimize their vitamin D and give them extra calcium, particularly after they've had the infusion, either by, if they're taking enough dietary calcium intake, that's fine. Otherwise, give them calcium supplements for 3 days. Some people say 7 days. There is no evidence there, but at least 3 days would be good to actually give them extra calcium.
Okay, thank you, Prof. Zulf. I think many questions for today, and I think also the attendees and people trying to make the maximum use of your presence today, even in the not related to the topic of today. So another comment is, thank you, Prof, for the great talk. What about the kids, teenagers, or long-term high steroid doses who don't have fractures, but a DEXA scan of -4 to -5 standard deviation? Most of them are short and have some bone aches. Are they eligible for bisphosphonate oral or versus IV? Or shall we start with supplementing them with vitamin D and calcium?
Yeah, I think another very important question. And so we did a study many years ago looking at nephrotic syndrome, who, as you know, are given very large doses of steroids. And we found that their bone density, areal bone density was low because, of course, steroids stop you from growing. So these patients were generally short. And these are sort of frequently relapsing nephrotic syndromes, the ones who were on steroids for a number of years. But they did not have any fractures. However, when we looked at the natural history, the adult studies, then they had slight excess of fractures compared with the norm in the population from the UK General Practice database. So there is some evidence that using high doses of steroids are harmful in a non-inflammatory condition like nephrotic syndrome. But when you have inflammation, so if you have inflammatory bowel disease or juvenile arthritis, then that's a bad combination to have inflammation and steroids. So that is very detrimental. Now, whether you should treat them with bisphosphonates is, I think you need to go to the International Society of Clinical Densitometry guidelines. If you should look for compression fractures of vertebral bodies, and if you find compression fracture of vertebral bodies, they should be started on bisphosphonates regardless of their bone density. If they've got a significant fracture history, then you should do, but there is no role at the moment for prophylactic bisphosphonate therapy, though that is now being considered in boys with Duchenne muscular dystrophy. In the UK, just before I left, we were discussing a nationwide trial of prophylactic bisphosphonates in boys with Duchenne muscular dystrophy, because 60% of them get compression fractures of vertebral bodies, very high rate. And so the question was, why wait until they get fractures? Why don't we just try and prevent them? But the answer is not there
Very
yet.
challenging, yes.
Yes.
Okay, so many questions today about osteogenesis imperfecta, Prof. Zulf. So maybe we can get another presentation in the future for osteogenesis imperfecta, maybe, because it's there are many gray areas in this topic. So another question from anonymous attendee is for osteogenesis imperfecta. How frequently should we follow them with DEXA scan?
Yes. So the one thing which I didn't cover is that you need to actually look at the like any measurement. When if you do the same measurement again and again, there is variation, and the repeatability in DEXA scans is very, very good. But it's still, there is repeatability in children can be about sort of 2% difference. So if you measure the 10 times, the same child in the same area, there will be at least 2% variation. So the meaningful effect should be 2.5 times the variation that you have. And if you do it 6 monthly, that you could just be measuring normal variation. So generally speaking, in the UK, we adopted in our sort of bond society, British adolescent and BPAC, I'm almost forgetting the name, the British Pediatric Adolescent Bone Group, that we would do annual bone density scans. Though if there are some research protocols, I'm data monitoring on the committee of number of trials, they're actually doing 6 monthly, and I've actually said that is too soon because of the variation. But you can't change protocols. So, but in clinical setting, I think annual measurement should be enough.
Okay, so annual measurements for patients with osteogenesis imperfecta regarding this DEXA scan. So another question is, what's your opinion for optimum bone health for thalassemia children? And I think this applies for all chronic patients with bone disorders, right? So.
Yeah, I think you're absolutely right. It applies to all chronic illnesses. So obviously, I think optimize their diet. They should have adequate dietary calcium intake. We've talked about vitamin D. One thing which is gets overlooked is weight-bearing physical activities. And I think, as you know, a lot of the teenagers now spend most of their time in front of their tablets, or phones, or playing games, and going out and kicking a football, or things has become less and less, and loading of the skeleton is very important. Remember that 40%, for example, if you take a girl, 40% of the total bone mineral content is going to be laid down on either side of menarche. So those 4 or 5 years are so important in accruing your building an adequate things. And this is a time when they're either doing so much homework or spending all their time on social media, and weight-bearing physical activities has gone through the roof. So that is not only, that's for public health, but it applies equally to people who have chronic illnesses. And then, of course, control the underlying illness. So just as I mentioned, in somebody with Crohn's disease, control of inflammation in these days with biologic agents is very, very important. And what I observed over 30 years was that we used to see lots and lots of fractures in juvenile idiopathic arthritis and inflammatory bowel disease, but with and less and less use of glucocorticoids, the fractures went down.
Okay. So, Hussain, can you go for the? I cannot see the. Okay. Another question is, we have patient with explained fracture, femur fracture. His management include internal fixation, and currently more than 4 months he's on wheelchair with minimal involvement or minimal movement, sorry, and is still expected to stay on wheelchair a few months more. Do you recommend DEXA scan later on for this child?
So this is a child who has an internal fixation of a fracture and is still a wheelchair user. I think if you're going to be immobile, you're going to lose muscle. When you lose muscle, you're going to lose bone. There's data for people, adults who've had, broken their femurs in trauma or skiing accidents. When you put a whole leg in a cast, within sort of about 6 months, you can lose 20 to 30% of your lean body mass, and that about 10% of bone mass. So it is a problem, but the important thing is not the DEXA. The important thing is that to get on and have good physical therapy to actually build up those muscles, which will then help to restore bone strength. DEXA is not going to guide you. I think it is almost universal that if you're immobile, you're going to lose muscle and you're going to lose bone. So get on with physical therapy.
Okay, thank you. Another question from Amani is, shall we continue to give hyaluronic acid to osteogenesis imperfecta cases after normalization of bone mineral density? It's for OI patients.
Yeah, this is a very important question. I think especially once the growth is finished. So there is no consensus about this. And I think as the transition for bone problems has become more and more developed, this is a question which was discussed a lot in the UK. And what we decided to do was, especially in young ladies, we started to wean them off bisphosphonates when they became sexually active. And as you know, in a different society, girls often became sexually active quite early. And these drugs are teratogenic and they hang around your system for quite a long time. So once the linear growth is finished and their patients are asymptomatic, not getting any fractures, then the option was either to stop the bisphosphonate therapy Or if they were not sexually active or had good contraception in place for girls, then you could go on to oral bisphosphonate therapy. For boys, again, we either stopped or put them onto oral. But in adults, the osteogenesis imperfecta becomes a low turnover bone disease. The reason we use bisphosphonates is to shut down the high turnover. And so the need for bisphosphonates becomes less. Though there are a group of adults who still continue to fracture, still continue to have pain, and in those cases, perhaps oral bisphosphonates is the answer. You don't need to give them intravenous bisphosphonates at that stage because you don't have such high bone turnover.
Okay, so Dr. Salwa asked me to take over with the question. So question from Dr. Randall Qaisi, what kind of guidelines we could refer to? I think you mentioned one of them, Prof.
Which guidelines, sorry?
Asking about the DEXA and perhaps defining the osteoporosis, I gather.
Okay, so the International Society of Clinical Densitometry, as I mentioned, they review all the available literature on the fractures and DEXA, and then that data is curated systematically. And then there are experts, so-called experts, gathered in a room, and they vote and come up with these guidelines. And these are sort of revised every about 3 to 5 years. And the last iteration was 2019, and I hope that there will be one fairly soon. So that's by far the most important guideline that's used by most pediatric doctors. But there are individual guidelines for certain conditions. So, for example, conditions like Rett syndrome, which has got a very high burden of fractures. There are guidelines there. There are guidelines for cerebral palsy, which we touched on, and other conditions, inflammatory conditions. Leanne Ward from Canada has got an amazing consortium with all her Canadian colleagues where they systematically look at. They've produced a number of guidelines as well. So there are general guidelines, and there are also disease-specific guidelines out there.
Thank you. I think we still have more questions coming for osteogenesis imperfecta. And if you don't mind, Prof, we could arrange another webinar to talk about osteogenesis.
Absolutely.
So I'll dismiss, because the time constraints, I will dismiss questions related to osteogenesis imperfecta. I'll move on with questions related to DEXA scan. So anonymous attendee asked, should we wait to have fracture to decide treatment for osteoporosis in children? Because in adults, DEXA used to prevent fractures by early intervention. So in children, do you recommend other modality to search for osteoporosis in risky patients?
Yes, a good question. As I mentioned, that if you're an adult and if you have a DEXA scan and your T-score is less than minus 2.5, then you are diagnosed as having osteoporosis, and just based on the DEXA scan, you can be started on prophylactic treatment in order to prevent fractures. Just like if you have hypertension or lipid problems, you put on appropriate treatment to mitigate against the risk of strokes, heart disease, etc. That sort of intervention in children, there's absolutely no guideline about that. So at the moment, we have to either have compression fracture of vertebral body. If that occurs without significant trauma or intrinsic weakness of the bone, as described by Dr. Hanan, then that child is likely to have significant skeletal fragility and should be treated. Otherwise, they need to have a significant fracture history. In other words, 2 or more long bone fractures by the age of 10 years plus low size adjusted bone density. This is to prevent inappropriate use of bisphosphonates. And there is a very nice paper from Michael Wyatt who showed that there is a boy who had pain and possibly one fracture and was given escalating doses of bisphosphonates, and he developed iatrogenic osteopetrosis-like disease. So you can over-mineralize the skeleton and turn into marble, and that's a disastrous thing to do. So bisphosphonates are useful, but they should be used appropriately. DEXA has its shortcomings. It needs to be used by people who can interpret it properly. And when you combine that with good clinical evaluation, you can actually help patients. But otherwise, there are dangers involved with inappropriate use of DEXA and injudicious use of bisphosphonates.
Thank you very much. And a question regarding technicality, how to calculate the BMAD. Is it available in the usual DEXA report?
Yes, so I think if you have a modern DEXA scanner, this is the GE Lunar or the Hologic, not the Discovery, the newer Hologic scanners. There are 5 or 6 versions, but you need the top of the range version. Then it will automatically work out the BMAD. In fact, the Hologic uses the Manchester software, is built into that, but it's called to enhance software. And I very much hope, and I hope this will be an ASPED goal, that one day we'll have our own sort of reference database for a GCC area, and we can pool together and have a very robust database. That's not answer the question. So the short answer is yes, it can be provided by modern DEXA scanners.
Is this DEXA scan essential for those who need estrogen therapy?
Who need estrogen therapy? Yes. Well, I think it would be a useful adjunct, just as you know, if you want to see if your estrogen is helping to improve bone health. For example, in Turner syndrome, you know, there is a good amount of data, though I think PQCT is a much better scanner to look at that. Then it's useful, provided you know that the effect size that you will have is not going to be as great as you will get with bisphosphonates. And again, you need to be aware of the repeatability. So if there's a 2% change just through variation, and you get sort of 2.5% increase in bone density after 1 year of estrogen treatment, is that significant? So you need to be aware of the reproducibility value of your DEXA scanner before you interpret the data.
Nice. This question to Dr. Hanan. Anonymous attendee asked, Dr. Hanan, what made you think about leukemia in your patient?
Okay, a few things. First of all, her general symptoms. She has weight loss and night sweats, which is typical B symptoms. The other things, the MRI finding, which is the high signal intensity in T2 MRI, and the discrepancy between mechanism of the trauma and the severity of the vertebral fracture. She was falling down just from the sofa. It's around half meter. This is the things that make us think of leukemia.
Okay. And I guess next question is for me from Dr. Said Hussain. At which age we should start screening for possible decreased bone mineral density in children with CAH who are on hydrocortisone? My practice is basically for patients when they reach 5 to 7 years of age to start as an initial BMD screening to be considered at that age. And of course, perhaps I would screen earlier than 5 years if the child is at high risk. I would say high risk if the patient is having other chronic disease, for example, chronic illness, or if there's any family history of osteoporosis, or there's a poor growth, saying that the child perhaps requires high dose of steroids, frequent fractures, all of them make this child at high risk, perhaps needs earlier scanning. And afterwards, I would scan them every 1 year to 2 years as a follow-up. That's my practice. I don't know, Prof, do you have a different recommendation?
No, I think that's a very sensible approach. I think the bone health index is very useful. But again, it looks at the cortical bone. It doesn't look at the trabecular bone. So it will give you a good idea of possibly what happens in long bones. But I think I'm a great fan of bone health index, and I think it should be used. And we do bone ages, so you actually get a bonus of bone health index, and especially in CH, you know, bone age is very important, and you're getting an idea for their bone health. So yes, absolutely, it will. If it is low, then you can optimize their nutrition, ensure that they're not vitamin D deficient, and ensure that they're doing some sort of weight-bearing physical activities, which is going to be beneficial.
Right. And this last question, I promise. How can DEXA scan help in diagnosis of juvenile Paget's disease?
Juvenile Paget's disease is a totally different kettle of fish. It's a very different disease. It's you make the diagnosis not so much on DEXA. Plain radiographs will actually help you by giving very characteristic picture. The alkaline phosphatase is usually very, very high. The inflammation is very, very high. And if you happen to do a bone biopsy, you'll see beautiful sort of stacked appearance of sort of like cortication of the things. And we actually do have some, I mean, it's a very, very rare disorder, but like everything else in my neighboring, in Oman, actually, I think there is Mariam Al-Badi has got patient with,
Mariam, yes.
yeah,
Yes, yes.
and there may be many more. It's something that I only saw very rarely in the UK, but everything is more common here, and everything is more common in Oman.
We should invite you again to London. By this, I think we reached the end of today's webinar. Thank you very much, Prof Zulf, for being so helpful and supportive to the physicians here and offering these kind of webinars. So I guess now we need to schedule the next osteogenesis imperfecta webinar.
We have to catch this, yes.
So we'll give you a break, like a couple of months, and then we'll ask you to do the osteogenesis imperfecta.
I look forward to that, inshallah.
Perfect, inshallah. Thank you.
Thank
I look
you.
forward to seeing many of you in Medina, you know,
Inshallah.
in the ASPED meeting.
Inshallah.
Inshallah. Thank you.
For our attendees who stayed till the very last moment. Thanks for Selwa, who moderated the first half of the session, or the majority of the session. And thanks to Dr. Hanan for her interesting presentation. I wish you a nice evening, and we'll see you around. Thank you very much.
Just, Hussain, before we end, I just want to remind our attendees about our next webinar, which will be on 20th of this month. Okay. Regarding the theme would be bone, so I encourage you all to attend our next webinar. And thank you, Prof Zulf, for your kind presentation and kind help for us. And your presence today is really enriched the area of the discussion and everything. Thank you very much. Thank you, Dr. Hanan. Thank you, Hussain.
Thank you all.
I'll share the recorded webinar with you as a link on our ASPED WhatsApp group, as well as we're going to be available on the website. So keep looking.
Thank you very much.